So I'm Tari King, and I'm happy to be here this afternoon moderating this session with you today. We have our patient advocate, Yvonne Florance, and I apologize, we've all misspelled her last name. It's Florance, like you would expect, not Florance, but beautiful either way. We have an excellent panel of speakers here. Dr. Sarah McLaughlin from the Mayo Clinic, Dr. Stephanie Wong from McGill University Medical Center, and Dr. Atif Khan from Memorial Sloan Kettering. And so our focus this afternoon is talking about optimizing local therapy. And so as I was getting ready for this presentation, I came across this slide that I, in fact, used in a presentation here in 2017. So it's no surprise that we've been talking about how to optimize local regional therapy for many, many decades now. First with the shift to breast conservation in the 70s and 80s, we learned the importance of whole breast radiotherapy for reducing local recurrence in women undergoing breast conservation. And then with the really big impact in our field of sentinel lymph node biopsy in the 90s and early 2000s for our patients with node-negative disease, and then an even broader impact when the first results of Z11 were published in around 2010, demonstrating that for women with limited volume node-positive disease, that it was also safe to omit axillary node dissection. Now, since that time, of course, there have been many other studies supporting the safety of omitting axillary node dissection in women with limited volume nodal disease, either in favor of observation alone or in favor of axillary radiotherapy. We also have now seen this in patients undergoing neoadjuvant chemotherapy, where we are routinely offering sentinel lymph node biopsy for staging. Those who are pathologically node-negative can avoid dissection, and we await the results of the Alliance A011202 trial to help us understand if axillary radiotherapy is equivalent to lymph node dissection for patients who have residual disease after neoadjuvant chemotherapy. And now, even more exciting, we're moving into an era where we have data that supports omission of axillary staging altogether among some patients with early-stage breast cancer. But of course, none of these decisions to de-escalate or to do less surgical therapy are made in isolation, and we still do have plenty of conversations about when is it best to dissect, when is it best to radiate, and then how certainly does the omission of axillary staging altogether impact our radiotherapy options. And this will be the discussion of another session on tomorrow afternoon. But as our patients are living longer into the survivorship period, it's really important for us to understand how our local therapy decisions impact their long-term outcomes. And we know that any axillary treatment is associated with arm symptoms. So this is a survey study that we did looking at just under 900 young women diagnosed with breast cancer, either treated with sentinel lymph node biopsy or node dissection, and we asked them about their arm symptoms 1 year after treatment. And you can see among those having a sentinel lymph node biopsy, 6 to 13% reported arm swelling at 1 year, higher in those patients that had radiotherapy. And among women having lymph node dissection, 17 to 25% of women reported arm symptoms at 1 year. Not surprisingly, on adjusted analysis, the performance of a lymph node dissection was associated with the increased arm swelling at 1 year. And we also asked them about limitations in range of motion, and that was also significant in women who were overweight, had a lymph node dissection, or underwent PMRT. This, of course, is not just a short-term problem, though. This is a long-term problem. This is another cross-sectional survey study that we did of women now 10 years out from their surgical treatment, again showing a high rate of arm symptoms, anywhere from 31% in women having a sentinel node biopsy up to 47% in women having node dissection at 10 years after treatment. And those symptoms not only include arm swelling, but a high percentage of patients reporting pain and, again, limitations in range of motion, particularly in our women having lymph node dissections. So today, again, we have asked this panel of speakers to come and help us understand what the current strategies or options are to try to minimize these comorbidities for our patients. So Dr. McLaughlin, again, she will talk to us about surgical prevention and management of lymphedema, followed by Dr. Wong, who will help us understand the decisions for when to dissect and when to radiate. And then finally, Dr. Khan will help us understand how we can incorporate PBI into some of these decisions for our patients, again, to optimize local therapy while minimizing morbidity. So without further ado, I will ask Dr. McLaughlin to come to the stage. Thank you.
So thank you for that great introduction to the topic at hand. So I think if we go back to our days in medical school, the lymphatic system was really that forgotten part of the vascular system that we didn't really talk about. It is definitely known to scavenge bacteria, old cells, those types of things, return them to the circulatory system through the venous tract and the thoracic duct. And most of the time things go okay and we don't ever hear about it again. But when it goes awry, that's when we have problems. And about 10 million people in the United States live with lymphedema. And this affects about 30% of our breast cancer survivors. So we all know that when you have lymphedema, or patients that have lymphedema, this is a negative impact on their overall quality of life. It interferes with their ability to complete their activities of daily living. There's a significant cost to it, not just in financial cost, but also time, how long it takes them to do their maintenance therapy and these types of things on a regular basis. And so as a result of that, we have, as a community, have really tried diligently over the last many years to figure out ways that we can prevent lymphedema going forward. And as Tari outlined there's been this deliberate de-escalation of axillary surgery, specifically axillary intervention altogether, and we have seen some progress, with that in that regard, where lymphedema is viewed as a secondary endpoint. We've also then tried to look at preemptive education strategies. If we talk to our patients about this up front, tell them about what symptoms they need to look for, does that educate them better to identify these symptoms earlier when they're having them? We've also really supported a prospective screening and surveillance model, recognizing that there's a paradigm shift from where we used to be reactive to now being proactive in identifying these patients. We've really kind of debunked the myths surrounding risk-reducing behaviors, and we've supported and validated the fact that exercise is safe and does not further influence or increase the risk of lymphedema in our patients who are at risk. I think there has been some data related to prophylactic compression garments. This is probably the most robust study evaluating this. It's from India, 307 patients, high risk, all having axillary dissections. They were then randomized post-operatively to wearing a compression garment for 3 months versus not, and you can see that there's a significant reduction in the risk of lymphedema in the patients who wore a compression garment. This is at 1 year follow-up. So with that, what else can we do? What else can we do to try to help these patients to reduce the future risk of developing lymphedema? And really what the focus has been, and there's an explosion in the literature over the last 5 years, is looking at, is there an option for surgery to actually have a preventative role in the setting of lymphedema? And I think when you talk about what's the role of surgery, really kind of in this prevention arm divides into two categories. One is lymphatic preservation, and that's really what we see with reverse mapping. And the second I would quantify as lymphatic reconstruction, which over the years has gone by a number of different names. Lymphatic microsurgical healing approach, or lympha. There's a simplified lympha approach. There's prophylactic lymphovenous bypass. And I think collectively these all get referred to now, or kind of can fall under the umbrella of an immediate lymphatic reconstruction procedure. So what is axillary reverse mapping? So axillary reverse mapping is essentially the concept that you can map the lymphatics, in our case, from the arm and the lymph nodes that are draining the arm. So at the time of the axillary intervention, you could identify those and preserve those, removing those lymph nodes that are hot from the technetium injected in the breast, or the ones associated with axillary dissection. The injection is of a blue dye, or ICG, or fluorescein. It can be given in the upper arm like you see here, or it can be given in the web space of the hands. And then what you see here in that picture on the right, you sometimes have to look hard, but I outlined it there, but here's the lymphatic that then is preserved during the axillary surgery. The procedure was originally described in 2009, and over the course of the last 15 years, there's been a number of studies that have looked at this, all with varying rates of follow-up and with varying definitions of lymphedema. And essentially what they collectively show is that the identification rate of an arm lymph node is about 40 to 90%, and that ability to salvage those lymph nodes or lymphatic pathways is about 80%, and there is some evidence that would suggest that from a pooled incidence level, there is a reduction in the rate of lymphedema. Now, I think it is important when we talk about axillary reverse mapping that we consider some of the other technical terms that are associated with this, one being crossover nodes. So a crossover node is when there is technetium given in the breast, blue dye given in the arm, that sentinel node is both blue and hot, demonstrating that it's draining both the breast and the arm, and that happens in 3 to 20% of patients. The other is an arm node. An arm node is a node that isolated drains the upper extremity. So the question is, if you identify an arm node, can you preserve it? What's the risk of having metastatic disease in that lymph node? Overall, that range is about 9 to 43%. So by virtue of this, a crossover node is an arm node, but an arm node is not necessarily a crossover node. So we sought to look at this in our population at the Mayo Clinic. What we did was we had 133 patients with breast cancer. They all underwent an axillary lymph node dissection. An arm lymph node was identified in 55 of these patients. And then if you stratify that out, of those 55 patients, 71% of them had a positive lymph node within the axilla, and the other 30% had negative lymph nodes. Now, this is a highly high-risk population. 75% of the patients had neoadjuvant chemotherapy. So of those patients who had any positive lymph node within the axilla, 11 of those patients had a positive arm lymph node. And the patients that had a positive arm lymph node actually had higher risk features of their disease. They were much more likely to have PN2 disease than there were the patients who had a negative arm lymph node, and they also had a much larger focus of metastatic disease within the axilla. The other interesting point is that the only positive lymph node in 3 of these patients was, in fact, the arm lymph node. So I think that what we concluded from this was that in a contemporary axillary dissection population, the positivity rate of the arm lymph node is relatively high, and leaving arm lymph nodes may not be oncologically safe. Remember, when axillary reverse mapping and saving the arm node was originally described, this was in 2009. This preceded Z11. So how we've changed the approach to the axilla over the last 15 years is significant, and maybe preserving an arm node now is very different than preserving an arm node would have been 15 years ago. The Alliance did do a prospective randomized trial on this, phase 3 trial 221702. This was patients having any type of axillary intervention who are then randomized to axillary reverse mapping with lymphatic reapproximation or not. It has completed enrollment, 36-month follow-up. We are in that follow-up period and awaiting these results to help answer some of these questions. What about immediate lymphatic reconstruction? Again, this is kind of that catch-all term for essentially what is, at the time of axillary surgery, performing a lymphatic to venous anastomosis. It's an invagination or dunking technique. Again, mapping this with the blue dye from the arm helps identify those lymphatics. So here's some real-time pictures. It's usually performed with an 8 or 9-0 non-absorbable suture in an end-to-end or end-to-side fashion. It's done under loop magnification or microscope magnification. So originally described by Bocardo in 2009 was a microvascular surgeon performing the procedure. Osmond then in 2019 kind of amended this and then coined the term S-lympha, which is simplified lympha, where if you ask my partner what he will tell you, the only thing simplified about the procedure is that you don't have to schedule the case with the plastic surgeon. But the technical component of still performing that anastomosis is still significant. So I think, there's been a lot of data in this area, and honestly, not a lot of the data is very good. This is a good representation of that. What you see is they pooled 19 studies, and you see the heterogeneity and the quality of the studies that are identified here. I think it is interesting to look at this data, though, because it does reaffirm some of the things that we've known about lymphedema for a long time, which is, number one, the synergistic effect of axillary dissection and axillary radiation therapy. These studies, again, only 106 patients who had the lympha procedure, but they did show some directionality, suggesting that when lympho was performed with an axillary dissection, with or without radiation therapy, that there was a decrease in the rate of lymphedema in the patients who had the lympha procedure. So I think where I want to go with this is over the last 2 years, there's 18 months, there's probably been 4 studies that have been very rigorous that have looked at this and provide us with some data around this topic. And the first one here was a prospectively collected a cohort of patients that was retrospectively reviewed. 41 patients had axillary dissection and immediate lymphatic reconstruction. Compared that to the axillary dissection only arm, and you see a significant reduction in the rate of lymphedema among those patients who had immediate lymphatic reconstruction, and that in fact on multivariate analysis, the only factor that sticks out is increase in that risk for developing lymphedema is having an axillary dissection without a lymphovenous bypass. Now I will draw your attention to the fact that the median follow-up of this study is only 13 months, and we know that the average time to developing lymphedema is much longer than that. So this is probably the most robustly and rigorously designed trial looking at immediate lymphatic reconstruction in a population of patients with high-risk disease. This is the Memorial Sloan Kettering data. All these patients had an axillary dissection. 144 patients were then intraoperatively randomized after it was already determined that there was a feasible lymphatic and vein that were amenable for anastomosis. When this was done, what they see at 12 to 24-month follow-up is there is a significant decline or reduction in the incidence of lymphedema in those patients who had immediate lymphatic reconstruction. And in fact, when they looked at some of the patient-reported outcomes, with the exception of that 18-month time point when it appears that there's a significantly higher number of patients who had compression garment use in the axillary dissection only arm, there's otherwise no significant difference in compression arm usage. And if we look at the graphs on the right side, where we might see an absolute improvement in physical domain and functional domain on the quality of life scores, these were not statistically significant at any time point. The next analysis of this data is in fall of 2025, and I think that's really important because the long-term durability of this data is really going to inform how we might move this procedure forward. The reason that I say that is because if we look at this study, which was Shelley Feldman's group, also from New York, who worked very closely with Picardo and published the first series of lympha in the United States, now has 4-year follow-up of their data, 90 patients, 45 patients had axillary dissection, 45 patients had had axillary dissection and no lympha, so 45 lympha, 45 no lympha, all had axillary dissection. And what you see at almost 5-year follow-up is that there's no difference in the lymphedema diagnosis rates, even when you included things like obesity, radiation, and these types of things, which suggests that the durability of these procedures is not known. We looked at our data again at the Mayo Clinic. My partner, Jim Jacob, designed a prospective trial for us. It was a 2-site prospective pragmatic trial where the cohort assignment was done at the surgeon level, similar to a 2-arm cluster randomized design, but 230 patients, 131 of who had immediate lymphatic reconstruction, and then we defined lymphedema by objective, subjective, and diagnosis code criteria. And what you see here is that when you look at the breast cancer population and you see that green box there, this is the 131 patients who had axillary dissection with immediate lymphatic reconstruction. Again, you look at the population. 75% of these patients had T2 tumors or greater, 77% of them had neoadjuvant chemotherapy, and 43% of them had N2 or N3 disease at the time of surgery after neoadjuvant chemotherapy. There was no difference in the number of positive nodes, the size of the metastasis, or extranodal extension between those patients who got an immediate lymphatic reconstruction and those who didn't. What you see is that we were able to perform an immediate lymphatic reconstruction in 88% of the population, and that we had this where a microvascular surgeon performed the procedure, the immediate lymphatic reconstruction in 37%, while the S-lympha was performed by the breast surgeon in about 63%. What you see is that, now, first of all, these curves are a little bit different than what we saw in the previous studies. These are freedom from lymphedema curves, so it's actually better to be higher than it is to be lower. And what you see is that there is no difference on multivariate analysis, especially after propensity score matching, in the objective rate of lymphedema, in patient self-reported rate of lymphedema either. What we do see is that maybe there is a difference if more than one lymphovenous anastomosis were performed compared to only one, and that maybe there is some separation of these curves related if a microsurgeon did it versus the breast surgeon doing it. Now, that would be unfortunate because if the data actually pans out long-term that this is actually true, it probably would further increase the disparities in care available to our patients. That being said, the study was underpowered to look at the number of lymphovenous anastomoses or the microsurgeon versus breast surgeon piece, but essentially we concluded that there was no difference in the rates of lymphedema in a 2-arm prospective trial between patients undergoing axillary dissection with or without immediate lymphatic reconstruction. So how do we conclude on this? I think we can say that reverse mapping is feasible and that preservation of the arm nodes, I think, is still in question. We await the results of the prospective data looking at long-term lymphedema rates and nodal positivity in those crossover and arm lymph nodes. I think immediate lymphatic reconstruction, there's no doubt, this is technically challenging. The early results are promising, but the long-term durability, I think, really remains the question that we have to answer. So the patient need is clearly that we need better risk stratification. We need personalized treatment and intervention strategies. We need a multidisciplinary approach. We need to validate our indications for intervention. We pooled our data with the Sloan Kettering group, trying to identify and develop a nomogram to maybe better predict these patients. What can we use preoperatively? What variables do we have when we're sitting there with the patient? And then how do those change postoperatively with any additional information we have at that point? You can see the areas under the curve are actually quite good, almost 0.8 and almost 0.9 in each of those settings. So let's switch gears here. What about surgery for a cure? When we think about surgery for a cure, it really comes down to 2 components. One is reconstructive surgery. Are we able to reestablish the normal homeostasis and physiology of the lymphatic basin that we're working on, or is it a reductive option where we're basically removing fibrous tissue and fatty deposition? So I think to have this conversation, we need to go back and think about the stages of lymphedema, where we see that patients, there are progressive stages of lymphedema, subclinical, where there's impaired lymphatic transport, but there may not be any visual signs, progressing to something that is a reversible edema, to something that's non-reversible, to something that is fatty deposition and elephantiasis when you see in really advanced rare cases. And I think these also correlate with the ICG lymphography staging scale, which essentially looks at patent lymphatics, functional lymphatics, and their pumping ability, as well as dermal backflow. And you can see that as you progress through this scale, that those things get worse. You lose functionality, have increased backflow. And this really should be another argument for the prospective screening and surveillance model, because intervening early is easier. As you get further down that path, the intervention becomes more complicated. Maybe it requires multiple procedures. The reality is that about 90% of our patients aren't screened and aren't ever asked about whether or not they have any symptoms related to lymphedema, which is a problem. And that's a problem because subclinical lymphedema is really emerging as being a true risk factor for the future development of clinically significant lymphedema. So this is the MGH group, and what their data demonstrates is that in the population of patients that had an axillary dissection, almost 40% of them demonstrated subclinical lymphedema defined as a volume change objectively in the arm between 5 and 10% when relatively compared to the other side and their baseline measurements. And that 40% of those patients went on to develop lymphedema. And in fact, even in the sentinel node biopsy, the numbers are a little bit smaller, but the trend is still the same, 24%, and then 11% of those patients went on to develop lymphedema. And those numbers are clearly higher than the incidence we see in lymphedema in a pooled analysis. So any type of surgical intervention we do for cure is going to have to be compared to kind of the cornerstone, the tried and true of lymphedema management, which is complex decongestive therapy. The goals of this are to decrease swelling, fibrosis, cellulitis, and it really falls into two phases. One that is a reductive phase, reducing the volume of excess fluid and tissue that is within the limb. And then once you've achieved that maximum reduction, then you move to the maintenance phase where you're trying to maintain that volume reduction. It's an older slide, an older study, but still makes the point that what you see from an edema reduction standpoint across these various techniques associated with complex decongestive therapy probably ranges between that 20 and 30% in most cases. So I'm not really going to spend a lot of time talking about the volume reduction type procedures. Liposuction is really considered the gold standard these days, as opposed to what was previously a large open resection and skin grafting or muscle flap closure. Now it's really liposuction is the primary debulking procedure. This is a different cannula than what is used cosmetically. It's a larger bore because you have to get through that fibrous tissue, which is within the arm. It is highly effective, though. I mean, it reduces the limb volume by about 100%, and it's so successful from that perspective. The problem is that once you reduce that volume to continue to control the fluid that happens within the arm, these patients are relegated to lifelong compression, strict compression therapy, wearing a garment all the time, or that fluid will reaccumulate. So what about lymphovenous anastomosis or lymphovenous bypass? So what you see here, this is obviously magnified. The pictures on the left, 4.5 times. The pictures on the right, 20 times. You can see that the mapping is performed again with the dye. The appropriate lymphatics are identified. The anastomoses are performed as previously described. I think what is interesting in this population is that there is some data that suggests a lymphovenous anastomosis actually remodels the subcutaneous tissue. So what you see here in this population of patients who had lymphovenous bypass performed, that in those patients, they actually demonstrated a decrease in dermal fibrosis and TGF-beta-1 expression, which is a result of them decreasing the local tissue inflammation, hyperkeratosis, and epidermal proliferation. So this is, suggesting that we are trying to restore and successfully restoring some of that physiologic homeostasis and normality to the arm itself. What about lymph node transfer? So vascularized lymph node transfer, the goal of this is really aiming to bring functional lymph nodes into an affected site. And it's thought to work two ways, one of two ways. One is either by the excretion of VEGF-C, which then promotes lymphangiogenesis, or the second is the lymph nodes acting as a pump. This can be done as an orthotopic or heterotopic procedure, so orthotopic into the affected basin. Maybe that's more effective. You scoop out all and clean out all of the fibrous scar tissue, and you put the nodal transplant into that. Heterotopic would be, in our case, it's usually at the wrist, which then the node packet acts as a pump. Most of the literature on this is very narrative and heterogeneous, and the harvest sites can be quite, varied across the entire body. So there we go. Okay, so this is just an example. This patient had the nodes harvested from the submental location. She has a really nice outcome after those are performed. This is placed then in an orthotopic fashion after the scar tissue has been removed from the axilla. So there has been a prospective randomized trial. This was a double-blind placebo-controlled trial performed in Finland and Sweden across 5 centers. They had 39 patients with breast cancer-related lymphedema after some type of axillary procedure who had lymphedema for less than 5 years. They were randomized to, all the patients got the lymph node transfer. They were then randomized to getting extra injected VEGF-C versus not. What you see here with the graph on the right is that in both arms, there was in fact a 20% reduction in volume within the limb, but the additional VEGF-C did not necessarily impact or improve the volume reduction. So how do we come about outcomes? I mean, it's a busy slide, but how do you compare complex decongestive therapy, lymphovenous anastomosis, vascular lymph node transfer? This combination of studies tries to get at that, again, looking across multiple studies where you see CDT is about a 10 to 15% reduction. When we move to lymphovenous anastomosis and vascular lymph node transfer, it's maybe in that 20 to 30% range, and that it actually doesn't matter where the lymph node is harvested from, that the outcome is still the same in terms of volume reduction. So how do you decide? Lymphovenous anastomosis is relatively easy. It's small incisions on the patient's arm. They can do multiple incisions. It's an outpatient procedure. But these patients, it's usually after failed conservative management. They might have recurrent cellulitis. They definitely still have evidence of functional lymphatics. There's minimal fibrosis or fatty deposition, and we're getting better at actually evaluating this beyond lymphography with better techniques like ultrasound to look deeper within the arm. But these patients also have to have normal venous pressure and minimal hand swelling. What about the vascular lymph node transfer standpoint? These patients tend to have more fluid accumulation. They tend to be in later stages. They might have fewer functional lymphatics, probably significant clinical hand swelling, which would suggest that there's a terminal component of the disease, or terminal damage to the lymphatics themselves, and then severe recurrent cellulitis. So again, the data here is not very good. People don't necessarily agree on the postoperative management. They don't necessarily agree on the definitions of lymphedema, but when we look across a broad spectrum of this analysis here looked at 71 articles. They found 16 where patients had undergone lymphovenous bypass and compression, 17 with vascularized lymph node transfer and compression. Again, low quality data. You can see the limb volume or the limb circumference reduction there. So this is a little bit different than what we were talking about. This is circumference, not necessarily volume reduction, but they were unable to come up with a consensus on which procedure was more effective, and the timing of the role of debulking surgery remains in question. So I put this here. This was published just this year, not with the intent of you to follow the whole algorithm, but to understand that essentially how this is approached is patients are either determined by advanced imaging to have a predominantly fluid component or a predominantly fatty component, and then that determines kind of which pathway they follow. And it can be that you actually repeat the same procedure if you deem after that procedure that fluid still remains the problem, so you're going to do more lymphovenous anastomoses, you're going to take them back or whatever. Maybe you then convert them to a lymph node transfer because of the different functionality that you see. Maybe you need to add a debulking procedure to this as well. So it's complicated, but you can see these in some way almost circle back and loop upon each other. I do think what's really interesting is the new science in this area. The Stanford group is looking at the nanofibrillar collagen scaffold. So they did this after a physiologic procedure. So all of the patients had either a lymphovenous anastomosis or a lymph node transfer. They were still having symptoms, so they went in and they implanted this nanofibrillar collagen scaffold, which then promotes lymphangiogenesis. And what you see is among those patients who received the scaffolding, they had further reduction in their limb volume, and that this was significantly more than the control population. So what did they conclude was that the scaffold placement resulted in more new lymphatics, collectors, and decreased dermal backflow, and that it enhanced the overall effectiveness of physiologic procedures. So what about the donor site? Because this is a real concern, and especially in the lymph node transfer. If you believe that there's any genetic component to how patients develop lymphedema, then you would argue that all of their sites are at risk of developing lymphedema because you remove lymph nodes. So it's interesting here because what you see in this population of patients who is actually having a breast reconstruction at the same time, they were harvesting lymph nodes from the anterior abdominal wall or growing areas. They mapped the lymph nodes by using reverse mapping in the leg to protect the lymph nodes draining the leg and remove only the ones that were not noted to be identified by the reverse mapping. And what you see is when they did that procedure that the mean volume differences between the two legs, the one that had the lymph nodes removed versus the one that didn't, was very low and not statistically significant. Quality of life. What we see in the quality of life space, again, is not a lot of good data. What I'll tell you here is this slide and the next slide, they're both the same after lymphovenous bypass or vascularized lymph node transfer. What it shows is varied follow-up. Half of the studies basically use a validated tool, half don't, but most of them demonstrate that there is some patient-reported outcome improvement after these procedures. So they may not eliminate their need for daily compression, but they are getting some type of symptomatic improvement. So as I close here, what I'd like to show you here is that the surgery piece is included in the NCCN guidelines, but it's usually in a multidisciplinary fashion. So with that, I think we can say that surgery prevention is gaining traction, but the durability of surgical prevention remains unknown. Axillary reverse mapping is actually easy to perform and may be beneficial, but surgery treatment for lymphedema really needs a multidisciplinary team and can reduce long-term symptoms, but the data is still lacking. So with that, thank you very much.
Thank you very much, Dr. McLaughlin, for that wonderful presentation. I'm sorry, I should have said earlier, we will hold our questions till the end. We'll have plenty of time for a panel discussion. Thank you to those who are already putting them into the website here, and we will, again, have questions here as well as microphones in the room. So now it's my pleasure to introduce Dr. Stephanie Wong from McGill University in Canada, and she will talk to us about when to radiate and when to dissect. So thank you.
Thank you, Dr. King. And I want to thank the organizers for the opportunity to present today on axillary management. Here are my disclosures. So today I wanted to talk about the axillary management trials that have been performed over the last 5 decades, focusing both on patients with clinically node-negative disease, here on the bottom, as well as patients presenting with clinically node-positive disease, here on the top. And when thinking about these trials, I think it's important to remind ourselves that no published RCTs to date have ever shown a disease-free or overall survival advantage between dissection versus radiation. And because isolated axillary recurrences are such a rare event, it is very difficult to detect differences in local control between these two approaches. So with that in mind, we'll start off with our clinically node-negative population, and to do that, we'll go back 50 years to the era of the King's Cambridge and NSABP B4 trial. The B4 trial was designed to determine whether outcomes differed by local regional treatments administered in addition to mastectomy. The trial included over 1,100 clinically node-negative patients who were randomized to one of these 3 treatment arms with no adjuvant systemic therapy given, mainly because it was not standard of care at the time. So why NSABP B4 is so unique is because it was a pure local therapy trial. And if we think about separating local management of the breast from the axilla, we see that from an axillary management perspective, this trial was really randomizing women to axillary lymph node dissection versus axillary radiation versus axillary observation. We also know in the clinically node-negative women who underwent dissection that 40% had positive lymph nodes. So because of adequate randomization, we can safely assume that 40% of patients had positive lymph nodes that were left in situ in the other treatment arms. And yet, despite this disease being left behind after 25 years of follow-up, we know that axillary management had no effect on recurrence-free or overall survival. What we did see, however, was a difference in local control. So at 10 years follow-up, 18% of patients in the axillary observation alone group developed clinically evident progression of untreated axillary lymph nodes compared to the excellent and comparable axillary control rates in the axillary dissection and axillary radiation arms. But because only axillary lymph node dissection provided the means to stage the axilla, and because early adjuvant chemotherapy trials required pathologic nodal staging for subsequent chemotherapy decisions, axillary lymph node dissection really became standard management going forward for the next several decades until the 1990s, when sentinel lymph node biopsy was introduced as a less invasive alternative to stage the axilla. So at that time, we saw the Milan and NSABP B32 validation trials. And one of the things we learned from these trials was that in patients who had a positive sentinel node who went on to get dissection, that in over 60% of cases, the sentinel lymph node was the only positive node identified. So this led many of us to believe that axillary lymph node dissection was likely overtreatment for patients with this low volume nodal disease because the sentinel lymph node biopsy procedure was already clearing that nodal disease. So then we saw trials evaluating patients with sentinel lymph node micrometastases, randomizing them to dissection versus observation, as well as trials that incorporated or restricted their cohorts to patients with macrometastases, randomizing them to dissection versus observation, as in Z11, or dissection versus radiation, as in Ameros. And what we see across all of these trials of clinically node-negative women undergoing upfront surgery with a positive sentinel lymph node is very effective local control with omission of axillary lymph node dissection, less than 2% risk of axillary recurrence at follow-ups out to 10 years. So axillary recurrences, which are usually an early event, are also a rare event for patients who meet eligibility criteria for these trials. But when thinking about those eligibility criteria, it's also important to remind ourselves that the majority of these trials restricted their cohorts to patients with clinical T1, T2 tumors, those with a maximum of 2 sentinel lymph nodes positive, and the majority of patients underwent breast conservation. So where we saw controversy and now evolving data are really in those groups that fell outside of eligibility criteria for these trials or who were not well represented in them. And the first group are the clinical T3 patients, as well as those with extracapsular extension. So the recent trial that specifically expanded eligibility criteria to these patients also happens to be one of the largest sentinel lymph node management trials published to date, the CINEMAC trial. This trial included 2,500 patients with clinical T1 to T3 breast cancer undergoing breast conservation or mastectomy with up to 2 macrometastases on the sentinel lymph node biopsy. They were randomized to sentinel lymph node biopsy alone versus completion dissection with nodal radiation administered per national guidelines, which is an important point because the majority of patients on this trial received nodal RT. The primary endpoint was overall survival, but last year at this meeting, we saw data from their secondary endpoint of recurrence-free survival, which showed no difference at 5 years between the 2 treatment arms. Now note here the cohort characteristics of this trial are highly representative of what we see in the modern era of women undergoing upfront surgery. The median age was 61, the majority of patients had T1, T2 tumors and hormone receptor positive disease, and as mentioned before, just under 90% received nodal RT. So this trial is more comparable to, say, that of Ameros than to Z11. And when the authors evaluated clinically relevant subgroups for which we previously had very little data, we saw the first compelling evidence that patients with T3 tumors or those with extracapsular extension do just as well with sentinel node biopsy as they do with axillary dissection, provided nodal RT is given. So that brings me to the mastectomy population, which is a group that has always garnered controversy, mainly because they were felt to be different from the breast conservation population due to more extensive multicentric disease, but also because they don't receive incidental radiation to the level 1 axilla that we see in over 70% of breast conservation patients who undergo whole breast radiotherapy. Until recently, they were also less well represented in clinical trials, although over the last several years, we've seen more data that has helped us refine what we do in the mastectomy population. So starting off with patients who have undergone mastectomy and have sentinel lymph node biopsy micrometastases. We know that the IBCSG 2301 and AATRM trials included small numbers of mastectomy patients who were randomized to dissection versus observation and have shown axillary recurrence rates of less than 2% now at long-term 10-year follow-up. Again, these patients did not receive any PMRT. We also recently saw data from the single-arm CENOMIC trial. This trial included significantly more mastectomy patients, albeit with shorter follow-up, and showed a less than 0.5% risk of axillary recurrence at a median follow-up of 3 years, further supporting the omission of axillary dissection and suggesting that PMRT is likely not needed for most of these cases. Now, that differs from what we see in the macrometastatic population who have undergone mastectomy, for which the strongest level 1 evidence currently supports the use of axillary radiation. And that includes the CENOMAC trial, which comparatively included a huge number of mastectomy patients, 920, and showed no difference between sentinel lymph node biopsy versus completion axillary dissection, provided that nodal RT was given. So if we have mastectomy patients with up to 2 sentinel lymph nodes positive with macrometastases, currently the strongest level 1 evidence suggests that axillary radiation should be given to provide effective local control. Now, we do have one trial that included mastectomy patients with macrometastatic sentinel lymph nodes that suggests that axillary observation could be used and we could omit radiation altogether, the CENODART-1 trial. And last year, the authors reported data specifically from their mastectomy cohort, which showed no difference at 5 years in recurrence-free survival between the 2 treatment arms, despite 92% of the sentinel lymph node biopsy-only arm not receiving any PMRT. Now, only 218 mastectomy patients were included in this trial, and the authors acknowledged that ideally more data and longer follow-up would be necessary to confirm the safety of sentinel lymph node biopsy only in patients selected for mastectomy, so they have since reopened this trial with the aim of enrolling 400 such patients starting back in June of 2022. To add to CENODAR-1, we will also soon see data in 2026 from the POSNOC trial out of the UK. This trial successfully enrolled 1,900 patients with up to 2 macrometastases on the sentinel lymph node biopsy and included patients that underwent mastectomy, randomizing them to standard adjuvant systemic therapy versus standard adjuvant systemic therapy with directed axillary treatment in the form of axillary dissection versus radiation to determine whether directed axillary treatment is even needed in the era of modern systemic therapies. In North America, we also have the TAILOR-RT trial, which is enrolling 2,000 women with biomarker low-risk ER-positive HER2-negative breast cancer, defined as an oncotype recurrence score of less than or equal to 25. So there will be patients in this trial treated with mastectomy and sentinel lymph node biopsy alone, who are then randomized to no adjuvant radiation versus PMRT with regional nodal radiation. So this trial, along with POSNOC and the expanded mastectomy cohort of CENODAR-1, should hopefully help us to resolve whether axillary observation alone for a patient with a positive sentinel lymph node with macrometastases is reasonable for our mastectomy population. Okay, now finally moving to patients with 3 positive sentinel lymph nodes, which is the group for arguably we have the least amount of data, and because this, the ASCO guidelines recommend proceeding with axillary dissection and considering comprehensive nodal radiation in this setting. We know they are a rare subgroup, but we are seeing a trend where these patients are increasingly managed without axillary lymph node dissection. This is data from the NCDB, where over 3,000 women with 3 or more positive sentinel lymph nodes underwent omission of dissection in up to 40% of cases in 2020. So what data do we have to support this approach? There are 2 published trials and 1 ongoing trial that have included patients with 3 or more sentinel lymph nodes that were positive. We know that AMROS included 71 such patients and randomized them to dissection versus radiation, although these probably weren't all macrometastases, given that 40% of the AMROS population consisted of patients with micromets and ITCs. The CENOMAC trial investigators were very specific about allowing up to 2 macrometastatic sentinel lymph nodes with additional micromets in 1 or more sentinel lymph node allowed, and so 52 such patients with 3 positive sentinel lymph nodes were included in that trial. And we also have the INSEMA trial, which is actually a sentinel lymph node biopsy omission trial that we'll see the final primary results of at the general session tomorrow. This trial included clinical T1 to T2 N0 breast cancer patients undergoing breast conservation with a negative axillary ultrasound and randomized them to no axillary surgical staging versus sentinel lymph node biopsy. But in the sentinel lymph node biopsy group, patients that have up to 3 macrometastases on the sentinel lymph node will be eligible for a secondary randomization to sentinel lymph node biopsy alone versus completion dissection, very akin to Z11. And so, although we don't expect there to be a large number of patients in this secondary randomization who have 3 positive lymph nodes, hopefully this will help to contribute some information about the optimal management of this rare population. And so next, not a rare subgroup, but certainly a current controversy. Should we be considering a return to the OR for more extensive staging with axillary lymph node dissection to determine eligibility for adjuvant systemic therapies? We know with the publication of Olympia and Monarch E that certain patients, specifically with ER-positive, HER2-negative breast cancer, are not eligible for adjuvant abemaciclib or olaparib unless they have documented N2 disease. And this has led to a number of colorful, multidisciplinary discussions as to whether or not we should subject our patients to a second surgery in order to obtain this information. And so in this climate, I think this post hoc analysis from the CINEMAC investigators was very welcome and a very elegant way to address this question. They looked at the CINEMAC study participants and determined which patients would have been eligible for Monarch E cohort 1 should they have documented N2 disease, and then looked at their outcome by completion dissection versus sentinel lymph node biopsy. So the first thing they did was calculate the number needed to harm, which was 11 patients needing to undergo completion axillary dissection to result in 1 patient with severe or very severe impairment in physical arm function as determined by a validated measure of arm morbidity at 1 year. Next, they looked at the number needed to diagnose, which was 8 patients needing to undergo completion dissection to identify 1 candidate for adjuvant abemaciclib. And then they looked at the recent results from Monarch E to determine the number needed to treat to avoid 1 IDFS event at 5 years, which was 13. So taking all of these calculations together, they determined that 104 patients would need to undergo completion dissection to avoid 1 invasive disease-free survival event at 5 years, which was dramatically higher than the number needed to harm to result in severe or very severe impairment in physical arm function for 1 patient. And so I think this provides us with very strong quantitative data that suggests that the balance of benefits to harms does not favor a routine axillary lymph node dissection in these cases, that completion dissection is likely to do more harm than good. And with the recent FDA and EMA approvals of ribociclib, this question might become less and less relevant. So to summarize for our clinically node-negative population, omission of axillary dissection for axillary radiation or observation in eligible patients is oncologically safe in clinical T1 to T3 N0 breast cancer, undergoing breast conservation or mastectomy. That mastectomy patients who have micrometastases need no further treatment, whereas those with up to 2 macrometastases should be recommended PMRT with axillary radiation until further trials evaluating axillary observation report out. For patients with 3 positive sentinel lymph nodes comprised of both macro and micrometastases, that axillary RT may be reasonable, although the data are certainly still in evolution. And in the setting of sentinel lymph node positive disease, it is not advised to routinely return to the OR for completion dissection to determine eligibility for systemic therapies such as CDK4/6 inhibitors. Okay, so now switching gears to talk about our clinically node-positive population. And we'll circle back to the NSABP B4 trial, which included just under 600 patients with clinically node-positive breast cancer presenting with palpable lymphadenopathy. These patients were then randomized to axillary dissection versus radiation. And like the clinically node-negative population, we saw no difference in recurrence-free or overall survival between these 2 treatment arms at 25 years. But unlike the clinically node-negative population, we saw a therapeutic benefit to axillary lymph node dissection in terms of optimizing local control and minimizing the 10-year risk of axillary relapse in these patients with higher nodal disease burden. So axillary lymph node dissection really became standard management, not only because it adequately staged the axilla in this setting, but also because it was felt to be superior in providing local control. And then in the 1980s and 90s, we saw PMRT and regional nodal radiation trials, which demonstrated reduced rates of local regional recurrence and distant relapse when regional nodal radiation was added to axillary lymph node dissection in this high-risk node-positive population, making this really the standard of care going forward. At the same time, we also saw a trend towards increasing use of neoadjuvant chemotherapy for clinically node-positive patients, with improving PCR and nodal downstaging, particularly in triple-negative and HER2-positive subtypes. So that led to an interest in axillary de-escalation for patients post-neoadjuvant chemotherapy. And a decade ago, we saw 4 such trials that evaluated the feasibility and accuracy of sentinel lymph node biopsy in clinically node-positive patients who converted to clinically node-negative after neoadjuvant treatment. The Alliance Z1071, Sentina, SN-FNAC, and Guinea-2 trials all showed successful mapping in over 80% of cases, with a false negative rate that hovered just above the widely used acceptability threshold of 10%, unless specific technical parameters were met, including the retrieval of a minimum of 2 to 3 lymph nodes or the use of dual tracer. So these trials showed us that sentinel lymph node biopsy was feasible and accurate in this setting, but because all patients underwent completion dissection to determine the false negative rate, we had no data on the long-term oncologic safety of performing sentinel lymph node biopsy alone in patients post-neoadjuvant treatment. Now, fast forward 5 to 10 years, and we've seen several single and multi-institutional series which support the safety of this approach, at least in patients who are YPN0 and achieve an axillary PCR with axillary recurrences of less than 1% at 3 years follow-up. And you'll note that distant recurrences far exceed what we see in terms of axillary relapses. This year, we've also seen data from the Oncoplastic Breast Cancer Consortium on patients with residual ITCs post-neoadjuvant chemotherapy. This was a large international retrospective cohort study that included 583 patients with residual isolated tumor cells on the sentinel lymph node biopsy, targeted axillary dissection, or MARI, and 400 of such patients did not undergo completion dissection. But we saw no difference with omission of axillary lymph node dissection in isolated axillary recurrences or any invasive recurrence at 5 years with this study. So taken together, these studies support the safety of omitting axillary dissection in initially clinical N1 patients who achieve an axillary PCR post-neoadjuvant chemotherapy, including those with residual isolated tumor cells. So can we go further to tailor local treatment to the extent of residual nodal disease? Can we omit regional nodal radiation in those same patients who have an axillary PCR post-neoadjuvant treatment? And the answer to that question came with the NSABP B51 RTOG trial that was presented here last year. This trial enrolled 1,600 patients with biopsy-proven positive nodal metastases who underwent neoadjuvant chemotherapy and had an axillary PCR either on axillary dissection or sentinel lymph node staging, randomizing them to regional nodal radiation versus no regional nodal radiation. And after 5 years median follow-up, we saw no significant difference in the primary endpoint of invasive breast cancer recurrence-free survival or any of the secondary endpoints, including overall survival. So I think the group for which this data is most impactful are our post-mastectomy reconstruction population. In this trial, 42% of patients underwent mastectomy, and if randomized to the no RNI arm, it meant that they were able to omit radiation altogether. And here we see on exploratory subgroup analysis that these patients did not have poor outcomes with omission of radiation versus PMRT with regional nodal radiation. And the same is true for patients who underwent sentinel lymph node biopsy alone, which is reassuring because it tells us that we can de-escalate axillary surgery and radiation in the setting of an axillary PCR without compromising oncologic outcomes. So if we can de-escalate axillary management in patients who have an axillary PCR post-neoadjuvant chemotherapy, the next natural question is, can we omit or de-escalate axillary management in clinically node-positive patients who have residual disease? And the answer to that question will come to us with the Alliance A11202 trial. This was a complementary study to B51 that enrolled 2,012 patients with biopsy-proven positive lymph nodes that underwent neoadjuvant chemotherapy but had residual disease on their sentinel lymph node biopsy. These patients were then randomized to axillary radiation to determine, or axillary radiation versus axillary lymph node dissection, to determine if we could use axillary radiation in lieu of dissection without compromising oncologic outcomes, but perhaps minimizing rates of lymphedema. And it will be interesting to see some preliminary data from this trial on nodal upstaging in the axillary dissection arm at the rapid fire session tomorrow. I also just wanted to mention that there is sort of a similar study, albeit with more a mixed population in Europe, the TAXIS trial, which is enrolling patients who have residual nodal disease following neoadjuvant chemotherapy and randomizing them after tailored axillary surgery to axillary dissection versus regional nodal radiation, including the undissected axilla. So hopefully both of these trials together will contribute to our understanding of how we manage patients with residual nodal disease following neoadjuvant treatment. And so to conclude for the clinically node-positive population, omission of axillary dissection with regional nodal radiation is appropriate for clinical N1 patients who convert to an axillary PCR post-neoadjuvant chemotherapy, that for similar patients with residual ITCs, omission of axillary lymph node dissection is appropriate, although the role of regional nodal radiation perhaps remains less clear. These patients were included in B51, we just don't know how many. And for patients who have residual nodal disease, ongoing trials are evaluating whether axillary radiotherapy can be used in lieu of axillary lymph node dissection, and we hope to see those trials report out very soon. So with that, I want to thank you for your attention, and I also want to thank these wonderful colleagues who helped review slides or answered questions in preparation for this talk.
Thank you, Dr. Wong, for that wonderful and comprehensive overview. And so now to bring us home, Dr. Atif Khan from Memorial Sloan Kettering Cancer Center will tell us about the expanding role of PBI and how we should be incorporating that in light of our discussions of de-escalating axillary therapy.
All right, great. Thank you, Tari, and thank you to the organizing committee for inviting me for this talk. Super excited to be here with all of you today. Let's go to this. These are my disclosures. So we're going to cover quite a bit of ground today, and we have 25 minutes. I intend to stay on time, so we're going to go quickly. I want to begin with just kind of an overview of PBI and then talk a little bit about certain subgroups where I think there's some confusion or debate, or where I get asked a lot of questions. We'll look at the younger cohort of patients, as well as invasive lobular carcinoma and the data there. And then I want to talk a little bit about PBI in the era of sentinel node omission, because I think that's very topical right now. And then we'll talk just very briefly about PBI in the context of repeat breast conservation. So you might hear your friendly radiation oncologist talk about whole breast radiation. This has sort of been our gold standard for decades, and it's exactly what it sounds like. Radiation is delivered to the entire breast, and there's usually a additional boost dose of radiation that's delivered specifically to the lumpectomy cavity. That's referred to as a boost. It can be given sequentially, or it can also be given simultaneously with the whole breast radiation. And partial breast radiation is different. It's exactly what it sounds like, which is radiation delivered just to the lumpectomy cavity. And there are different ways of achieving that dosimetry. But the big idea here is that the radiation is intentionally delivered only to the margin of tissue around the lumpectomy cavity. Now, if you're in this room, you probably don't need to be reminded that breast radiotherapy is a necessary component of breast conservation therapy, dramatically reduces the chance of a local recurrence in the breast, but also modestly but clinically meaningfully improves breast cancer survival and even overall survival. It's a very important component of breast conservation therapy. And that leads to the question of like, okay, well, why are we even talking about this? Why do we even want to do this partial breast radiation? And this was partially born of the observation that in the seminal BCT trials that carefully coded where these recurrences were happening in the breast, the overwhelming majority, about 80 to 90% of these recurrences were happening in and around the lumpectomy cavity, which is not that surprising when you think about it, but this was demonstrated in those data. Now, when I used to give this talk, people would invariably come up to me, or either even just raise their hand or shout out the question or come to me afterwards and be like, well, what about the Holland data? And what they're referring to is a paper published in 1985 in which Dr. Holland, pathologist, performed whole mount sectioning of mastectomy specimens and sort of described the pattern of the distribution of microscopic residual within the breast, sort of also ultimately showing that about 40% of that residual was outside a 2-centimeter margin around the index tumor, and about 15% of that was invasive disease. And so I decided to sort of like make some slides on this, and what I always say, partially joking, is that people didn't really wait to see how the movie ends because there was more work that that group did. For example, there's this paper from Dr. Holland's group in which they looked at mammographic images as well as pathology information to try to ascertain which of these tumors were quote-unquote breast carcinomas of limited extent. And when you sort of took that synthesis of that information, you could pretty accurately, with a high positive predictive value, anticipate which of the tumors were going to be these breast carcinomas of limited extent, which were not extending beyond that 2-centimeter, what they call sector 2 of the whole mount specimen. And taking this idea one step further, if you look at MRI data, if it's unifocal on MRI, and then adding to that histopathology, again, you could very reliably define which tumors were likely to not extend beyond a couple of centimeters from the index tumor, especially if they were EIC negative. In addition to this, there's also this re-excision data in which re-excision specimens were looked at for sort of the maximum radial extent beyond the re-excision, like in the re-excision specimen beyond the index tumor. And this is a series that comes to us from William Beaumont, pretty large series of re-excision specimens. If the initial tumor, if the initial lumpectomy was negative by NSABP criteria, meaning no tumor on ink, the chance of having microscopic residual in the re-excision specimen extending beyond a centimeter was very low, under 10%. So when you take all of this together, I think what it means is that the available clinical and pathological data suggest that microscopic residual disease does not extend to the whole breast. Fast forward about 2 decades, and now we have multiple randomized trials of PBI, all of which have shown 2 things. Number one, the toxicity in the cosmesis appears to favor partial breast radiation in all of these studies, except for one, the rapid study is an outlier. We'll talk about that in a second. And 2, each of these studies has demonstrated non-inferiority of partial breast radiation versus whole breast radiation, except for the B39, which was not able to demonstrate equivalence. But the absolute difference in the IBTR rate in the 2 arms for each of these studies is just very, very low. Now, I want to call out specifically the Import Low trial. This is a British trial that did this experiment very elegantly because they didn't change the fractionation. You either got 3 weeks of whole breast radiation with a certain schedule, or you got 3 weeks of partial breast radiation with the exact same schedule. They also had another test arm here in which they intentionally reduced the whole breast dose. This is a very simple technique that's being used here. Kind of what they were positing was that they would see the lowest rate of elsewhere failures in this control arm, a slightly higher rate of elsewhere failures in this test arm 1, and then more elsewhere failures in the PBI group. But a very nice experiment, very clean, and what they found was that there was absolutely no difference in the rate of breast events across all 3 arms, including in the partial breast arm. And what was even perhaps more surprising to some people, although not to me, was that the partial breast arm actually had less toxicity, and for important endpoints such as change in breast appearance, hardness or firmness in the breast, and any treatment appearance. So it wasn't a surprise for me, because if you treat less stuff, you're likely to have less complications. And that's exactly what was shown in that trial. Now, another thing that people often will say is, well, are we just treating patients who don't actually need radiation, right? It's just a very low-risk population. Maybe they don't need radiation at all. And I don't really agree with that, and here's why. When you look at the outcomes of breast-conserving surgery and tamoxifen in women with low-risk breast cancer treated without radiation on these trials, the rate of recurrences trends around 1% per year. And it's very concordant across these trials. It's actually quite striking. About 5% at 5 years and about 10% at 10 years. Very, very consistent. If you increase the risk, the background risk in the population, those numbers start to go up as in the FILES trial and also in B51. When you compare these recurrence risks with the data that I showed you from the PBI studies, it's a lot lower. Now, obviously, this is a cross-trial comparison, but just at that level, you can see that there seems to be an active signal of efficacy happening in the PBI arms of these whole breast versus PBI studies. That seems to be less than the recurrence risk in the first generation of omission trials. Now, I will note that there is a second generation of omission trials which are using further, typically an expression-based biomarkers, but other ways as well to further pick out women who are likely to be what I call have very low-risk breast cancer. And what's interesting here is that in the early reporting from these studies, the IBTR rate does seem to be lower, trending at about 0.5% per year, 2.5% at 5 years, seen in the Lumina study, and also actually seen in the IDEA trial. So this may actually influence ultimately our thinking about how we should be treating these patients, or if at all, with PBI or any other treatment. So taken together, the extant whole breast versus PBI data supports that the equivalence of these two approaches in selected groups of women with breast cancer. A very large number of women are candidates for PBI, and it is an active treatment with a lower IBTR rate compared to endocrine therapy alone. And for women who are candidates for PBI, there really isn't a good reason to electively treat the whole breast, I don't think. And that gets us to the next part of the talk, which is the selection criteria for PBI. Now, the ASTRO consensus, convened a task force to update the guidelines, practical guidelines for use of PBI. These were the 4 key questions that the group handled. We're going to only look at the first one, which is who should actually get PBI. And they framed this very specifically as who should get PBI as an alternative to whole breast radiation. This is actually kind of a watershed moment to some degree, because for the first time, they actually recommended PBI as an alternative to essentially as a preferred alternative to whole breast radiation in women who had these specific features, grade 1 to 2 disease, ER positive. And somewhat surprisingly, age over 40, this was a departure from the prior guidelines, and also small tumor size. What was also pretty interesting was that PBI was conditionally not recommended for women who had lobular histology. And we're going to look at why they actually came to these conclusions. Now with DCIS, we see a very similar thing, small size, low to intermediate grade, same age, and pretty similar actually. So let's look at PBI in premenopausal and young women. What are the data there? And this is a kind of slightly expanded version of the data that I showed you earlier with 2 additional trials. And what you'll note here is that participation of women under 50 was actually quite limited in all of these studies, except for the B39 study, where in fact 38% of women were under the age of 50. So that's actually, and because that was the biggest study, 4,200 women, that's actually quite a bit of patients treated with PBI. So looking at the forest plot from B39 RTOG 0413, what's interesting here is that the data were reported as premenopausal or postmenopausal, about 800 women in each arm. So that's actually pretty robust data. But there were more events with partial breast radiation than with whole breast radiation. You can see here 4.8% versus 6.4% with a hazard ratio of 1.47. But this was not statistically significant, although you can see the trend there trending in the direction of favoring whole breast radiation. So what does that mean? Well, what we did, we have a concept right now that we're working in NRG to do a dedicated study in women, young women, women under 45, looking at different fractionation schedules. So we pulled this unpublished data that we pulled for that concept, and restricting the comparison only to external beam-based partial breast radiation, and looking at it both by premenopausal versus postmenopausal, or also by age using 45 as a cutoff. You can see that the rate of IBTR, or IBR, let's call it, is pretty similar in these two groups. And same thing for just any event-free survival, including in the women who are under 45 versus compared to women who are over 45. So that's pretty encouraging. I think the task force got this part of it right. It probably is quite all right to do PBI in younger women. Now, what about invasive lobular carcinoma? Well, here's that same graph again. It is true that there's a pretty striking lack of participation, sometimes by design, sometimes probably just by doctors not feeling comfortable with it, but there was very limited participation of women with invasive lobular carcinoma in the PBI trials. And when you put it all together, there's only about 250 women who were treated with PBI across all of these studies, of which there's 15,000 participants overall. Only 250 or so actually had invasive lobular carcinoma. That's pretty striking. So the discomfort that the task force had with this is I think, understandable. Given that data, we looked at our own series at MSK, 132 women with ILC or mixed histology, generally low-risk features, and with a follow-up of about 39 months, we saw 2 recurrences. It's 2 out of 132, so you can make what you will of it, but it seems to be okay. We have not used this as an exclusion in our own practice. Now, I want to switch to PBI in the era of sentinel node omission. When a couple of, I guess about a year ago, I collated these data and went to each of these protocols looking for their radiotherapy details, like how were the protocols mandating radiation. Some of them really didn't have any details in there. Some did. Some, for example, in Ensema, they expressly prohibited PBI. They also expressly prohibited high tangents or RNI in Ensema, so that's actually good because the experiments is a little more clean in that way. But you can see that there's some variation here, and also some of them just didn't have any details. And the first one to report was actually the sound trial. So you can imagine my excitement when I started reading this trial. It's like, all right, well, what did they do? And you can see that, not surprisingly, most of the patients on the study got radiation, as we would expect. And what was more interesting was that, buried in the text there, about 11% of women in both arms, in the sentinel node group as well as in the no axillary surgery group, received partial breast radiation in the way that's preferred in Europe, or certainly in Italy, the Elliott intraoperative electron radiotherapy as a method of partial breast radiation. So that's pretty interesting. And as you guys probably know, there was a very low risk, there was just very few events, both in terms of axillary recurrence and other events between the two arms on sound. So here's what I would say about radiotherapy in the era of sentinel node emission. These are contentions because I think we're still in the deliberation and contemplation phase of this. We don't really know exactly how it's going to play out, but here are my contentions. So if you have a clinically negative node per sound, or let's say Ensema criteria, you're very likely to be pathologically N0. We know that from the sound results. So it's probably okay to consider these women to be pathologically N0 and to consider their options in that way. Contention 2, a short course of PBI might be the sweet spot between treating everything and treating nothing for many women, possibly for most women. And contention 3, a short course of PBI may be a hedge against future noncompliance or discontinuation of endocrine therapy, which we all know is actually quite high. Now, finally, just a quick word on partial breast radiotherapy in the repeat breast conservation therapy context. We do quite a bit of repeat breast conservation in the setting of isolated in-breast recurrences. This is our experience at MSK, looking at salvage mastectomy and comparing that to repeat breast conservation therapy, demonstrating no difference in breast cancer-specific survival. You can see that these groups have some imbalances, but it's reassuring to see that, in fact, this appears to be a sound approach. And here's a larger cohort from Europe reported by Hanoun Levy, again comparing mastectomy as a salvage for IVTR to repeat breast conservation, which entails a second course of radiation delivered as partial breast radiation. They tend to do this with brachytherapy catheters, but again, showing no difference between the two groups with respect to distant metastasis and also disease-free survival. So this is to say that if at your center you're not offering the possibility of a second course of breast conservation therapy, probably should be. This is actually a pretty good option for many women. So to conclude, PBI is a very useful option for women with breast cancer, but it's still quite underutilized, primarily due to historical biases and just resistance to change. PBI clearly has less acute toxicity and probably less late toxicity than whole breast radiation. The proportion of women who are eligible for PBI has expanded and may continue to expand, especially as systemic therapy options improve. PBI utilization should not be affected by sentinel node biopsy omission. I think if we started to see an uptick in whole breast radiation, that would actually be counterproductive. And finally, re-irradiation with PBI has created a new and perhaps preferred alternative to mastectomy for isolated IVTRs. And that's it. Thank you.
Thank you, Dr. Khan. Again, a very nice presentation. So thanks to all of our speakers for staying on time. We do have a lot of time to get to our Q&A. We do have some questions here that have come in through the chat, so I'll give people time to go to the microphones, and I'll start with some of the early questions here for Dr. McLaughlin. So one of the old questions, is there any rationale behind avoiding blood draws or IV fluids, blood pressure measurements, et cetera, on the arm where axillary lymph node dissection was performed?
So that has been looked at. Probably the landmark study related to that, it comes from the MGH group, has a long prospective follow-up of about 700 patients. And those patients demonstrate that there's no difference in lymphedema rates with blood draws and blood pressure and those types of things. It's now in the NCCN guidelines that you do not need to avoid the arm with which you were operated upon, or the arm that had the lymph nodes removed. The reality is that most patients prefer to use the other arm, which is fine, and that's actually what the guidelines say is, use the other arm, but if you need to use the at-risk arm, that's okay.
Thank you. And microphone there.
Hi, Puneet Singh, MD Anderson. I had a question for both Dr. McLaughlin as well as Ms. McNeil regarding some of these techniques of immediate lymphatic reconstruction that were discussed. Anecdotally, it seems that many patients as well as clinical team members are thinking that we should be offering this to everyone, despite the fact that the data appear to be mixed in terms of results and whether they're durable or not. So I was just wondering if you could talk a little bit about how to navigate these conversations with patients who may come in asking for these procedures, especially when we know that, again, data are still kind of outstanding, as well as insurance companies may or may not cover these procedures.
I'll start. Yeah. Okay. So I think it's a good question, right? And I think that the truth is that while we don't know the durability of these long-term or what the results or outcomes are going to be, I think that there's definitely no harm that is done in these situations where the immediate lymphatic reconstruction is done in a prophylactic fashion. So I don't think you're adding risk to the patient. What you add is kind of the scheduling differences. If you're having a microvascular surgeon do it and you need to book a combination case, you're adding time to the procedure itself. I don't know about the reimbursement piece of it. I think, these are, complex questions. But I think this is a lot of what's happening. Like I said, there's been this kind of explosion in the literature. So definitely this is being done, even though we don't necessarily have the long-term data that tells us if it's effective or not.
Yvonne, do you want to add to that, the challenges for patients where some of these procedures may not be available to them in one city versus another, or really not knowing the long-term outcomes?
Well, the goal is personalized care for the patient. And so I think that we really have to defer that to the patient because patients' needs are really different. And so a lot of times, it's just the preference of the patient. So we have to keep that in mind as we move forward.
Thank you. And Dr. McLaughlin, just a follow-up to that. The lack of difference in the extended follow-up, what do you think that the pathophysiology or the reasons behind that may be?
Well, I mean, so again, if we think about the population of patients these days who are getting axillary dissections, I mean, they have pretty significant high-risk disease. So many of them are getting radiation therapy. It's probably scar, those types of things that happens as things heal. Plus, when we've done it, we've also restricted the range of motion, of these patients, going out. Initially, don't lift your arm up over your head. I mean, we're kind of really limiting people in that way because you don't know. I mean, you've got an anastomosis there. If you're doing only one, which in most of these cases, the average is like 1.6, so you're doing 1 to 2, and you're basically relying on that for the drainage of the arm. You can imagine what would happen with that, the patency and durability long term. So I just think we just don't know. It's probably fibrosis, it's probably scar, it's probably inflammatory changes that happen within the axilla in that healing period and recovery time.
Thank you.
That's my guess.
Microphone over here.
Very excellent talks overall. And I'm a radiation oncologist from Seoul, South Korea. And my question is regarding the immediate lymphatic reconstructions. I wonder, if the amount and extent of radiations delivered to the reconstruction site could impact the outcomes, impacts, and potentially rendering the procedure futile. So have you discussed this issue with your radiation oncologist, or is there any literature to address this?
I mean, I think that's exactly the point, right? These patients who are getting axillary dissections, these are your post-neoadjuvant chemotherapy who have residual disease, N2, N3 disease. They get 1 or 2 immediate lymphatic reconstructions, and then they go and get radiation therapy that's comprehensive regional nodal, so the impact of that. I mean, I think that definitely weighs into some of the durability piece, but there isn't anything, hopefully with the Memorial data, which was randomized and very rigorously designed, will give us some insight into that. But short of that, I don't see a situation where we would withhold radiation in lieu of preserving the lymphatic anastomosis, if we think that's the cause.
Dr. Khan, have you altered your post-mastectomy radiation treatment planning at all in the patients that have had this immediate lymphatic reconstruction in the context of the clinical trial at Memorial?
Great question. No, we haven't really. We haven't been taking that into account. And most of those women have indications for comprehensive radiation. So I think that piece of it is equal in both arms. Yeah.
Microphone over here.
Prasanna Alluri from UT Southwestern. I have a question about the PTV margins. I think a lot of the trials use pretty generous margins, usually 1 centimeter or higher. With increased technology, do you have any concerns about potentially shrinking the PTV margins? Should we take PTV at face value? If you have less uncertainty, can you reduce it to 5 millimeters, 3 millimeters? Or do you think because we're covering a larger area for potential microscopic disease, there's a risk of reducing PTV margins because we're blurring the definition between CTV and PTV?
Well, specifically for the PTV margin, it's very institution specific, meaning what kind of tech you're using. Do you have DIBH, for example? Are you using clips to match to? All of these things can play into how what that PTV margin should be. I think you're right. The PTV margin in the trials was probably excessive because they were done at a time when some of these technologies were not available and they weren't counting on people having clips, for example, uniformly. But if at your center you are invoking these different technologies, such as matching the clips every day, you can you can reduce that PTV margin. For example, we use 5 millimeters routinely. We match the clips. We also use DIBH. Other centers are using 3 millimeter margins. Results seem to be quite all right.
Could you comment a little bit further, Dr. Khan, on your preferred dose fractionation in PBI? And then also, what's your thoughts on the role of ultra-hyperfractionated whole breast RT versus PBI?
We have gone to using 6 gray times 5 fractions to 30 gray, the Florance, the so-called Florance schedule, just because it's kind of the shortest schedule that seems to be the sweet spot of getting the treatment done quickly and having level 1 evidence behind it. Now, with respect to, I get this quite a bit, like, all right, well, hey, like if the, I think when PBI was being investigated, it was often a question of convenience because it was, versus 3 or 5 weeks of whole breast radiation. I think that wasn't really the right framing of the question. The question really is, what is the target volume? And we should put the radiation where it's needed and not elsewhere. So I think that strictly speaking, to say that, oh, well, we have a fast way of doing whole breast and therefore we should just do that, that's really kind of missing the point. The point is, where is the disease? And let's put the radiation where the disease is. We shouldn't just electively treat an area that's not needed, right? For any given fibroblast, a day without radiation is a good day, and we should try to prevent that fibroblast from getting radiation. Now, that having been said, I think having the option to do whole breast radiation quickly is a good one, and it can be used, it should be used for, in the appropriate type of patient. I will say one thing, the 5-fraction whole breast radiation, that's without a boost. So now you're talking some way of doing boost after that. That's going to add, a couple of fractions potentially. And if you're not boosting, you're giving an unboosted dose. So that then restricts your patient eligibility potentially.
Thank you. Over here.
Peter Dubsky, I'm a surgeon from Switzerland. Thank you all for the very elegant presentations. We've recently moved to PET-CT in our clinically node-positive patients. I know not all patients are Swiss and have access to that, but I'd love to have your view, especially Drs. Wong, King, and of course Dr. Khan. If you have a PET-CT in your patient, does it help you with your axillary local therapy planning? Let's put it that way. Or does it leave you helpless?
Dr. Wong?
Oh, that's a great question. We do have PET-CT available, and in fact, it's our preferred method of staging for patients who present with clinically node-positive disease. And I think that information can sometimes be helpful when you're thinking about, after neoadjuvant chemotherapy, how many nodes were positive, how many nodes are we expecting to see treatment effect potentially in when we take that patient back to the OR for sentinel lymph node biopsy or targeted axillary dissection or whatever technique you use post-neoadjuvant chemotherapy. So we have been using it, and to some extent I do find that information helpful.
So a follow-up question then, which is, again, from the audience. So if you have this PET-CT, does the number of positive nodes on that imaging impact your decision to offer a sentinel lymph node biopsy to patients who've had a good response to treatment?
I think that's an excellent question. The trials that evaluated sentinel lymph node biopsy post-neoadjuvant chemotherapy really evaluated patients who had clinical N1 disease. And I think that's the major difference, is that we're not dealing with patients where we're looking at the number of lymph nodes positive when we're determining whether a patient is clinically node positive or negative. It's really the presence of palpable, movable axillary lymph nodes or matted lymph nodes. So it doesn't, in fact, influence our decision to offer sentinel lymph node biopsy post-neoadjuvant chemotherapy as long as clinically the patient has converted to node negative, clinically node negative.
That's the similar approach that we take in Boston. Dr. McLaughlin, anything different from your practice?
Yeah, no, I agree.
Can I just answer that? We also use that PET-CT information. Sometimes there can be IMN nodes that are hot on that staging, or even superclav. There's a different way that we differentially dose those areas, again, also based on how they respond to the neoadjuvant chemo. So that can become useful. And I agree, we don't count nodes in the axilla to determine, for example, whether there's an indication for PMRT or RNI after that neoadjuvant chemo.
Thank you. Amber alert. We'll go to the microphone over here.
Okay, quick comment and a question. I was saying on the lymphedema and the arm and the blood pressures and IVs, there's no data that's ever going to defeat 150 years of dogma. They shout the loudest. Nobody's ever going to, it's going to take a long time to change that, even though it's been true for 20 years. My question is for Dr. Khan. On your re-radiate, is this people that have been previously APB-bad or people that have previous whole breast radiation that you can go back and do partial breast and not rot their breast? You see what I'm asking?
Yes, I do, yeah.
Okay.
Most of that data has been in women who had whole breast radiotherapy as part of their breast conservation therapy. And their second course of radiation was delivered as partial breast radiation. Now, we are going to probably begin to see women who have a recurrence after an initial course of partial breast radiation. What we've been doing for them is, in their second course, we give them whole breast radiation. We essentially just reverse the sequence of those two things.
Sorry. Over here. Yes, thank you.
My question is to Dr. Khan. My name is Jacek Jasem, Medical University of Gdańsk, Poland. I understand that when you talk about PBI, you refer to external beam irradiation, but there are also some other alternative means that may be used for partial breast irradiation, such as applicator, a linear accelerator applicator, X-ray applicator placed in the tumor bed, or brachytherapy. Can you shortly comment on these alternatives?
Yeah, sure. We didn't get into the techniques because of time, but you're right, there are different ways of delivering partial breast radiation. I'll draw a distinction between the intraoperative approach, which is fundamentally different from the approaches that are taken once the pathology becomes known, right? Because in the intraoperative approach, you're kind of triaging a patient for a certain type of treatment without fully characterizing their risk. You don't know about the margins, you don't know about the nodes, et cetera. And I think that's partially why the IORT studies have been associated with higher recurrence risks, okay? So that's one thing. Now, in the post-pathology setting, whether you use applicators or external beam technique, I think both of those are okay, and the data are quite good for both of them. For example, that GEC-ESTRO trial was an exclusively brachytherapy trial. I think there's some expertise that's needed for that technique, but if the expertise is there, the results are very good.
Thank you.
Okay, we have a few questions on the chat here about management of the axilla, the surgical management of the axilla. Dr. Wong or Dr. McLaughlin, should patients who had one positive node prior to neoadjuvant chemotherapy and still have one positive node after, at the time of should they get dissection? So one positive node prior, still one positive node after treatment, should they get a lymph node dissection?
I can take a stab at that. So as of right now, we don't have the results from the Alliance A11202 trial, which is looking at patients who have residual nodal disease following neoadjuvant chemotherapy. So in this particular setting, at our institution, we have taxes open, so we try to put them on that trial. But I think the standard management would be completion axillary lymph node dissection in those cases.
Okay. And follow-up, what is the role of TAD then after neoadjuvant treatment? How are you utilizing TAD?
So we are using targeted axillary dissection, which is selective retrieval of the biopsy-proven positive clipped node that's localized prior to surgery and removed. There's, in our mind, good data to support that it can lower the false negative rate. And in the setting of, for example, failed mapping, I think it can be a very nice salvage. But there's also very compelling data that sentinel lymph node biopsy alone with dual tracer and retrieval of a minimum of 2 to 3 lymph nodes is really adequate. And so I think whatever you choose to use at your institution is very appropriate. That's what
I would say we get a lot of patients who are diagnosed outside, have a clip placed, and if they come to us and had a clip placed, then we try to retrieve the clipped node, so dual tracer mapping with a localization of the clipped lymph node.
I think we're all moving towards that direction, so using TAD when necessary, but if the node hasn't been clipped, then it's probably safe to just make sure that you retrieve 3 sentinel nodes, use your dual tracer, and be honest about the success of your mapping. So moving into the upfront surgery setting then, is it safe to omit radiation in mastectomy patients with multiple micromets? So maybe Dr. Wong and then Dr. Kong?
Are we talking BCT or mastectomy?
Is it safe to omit radiation in mastectomy patients with multiple micromets?
Yeah, I mean, I think this does come up non-infrequently. You have, 2, 3, 5 nodes involved but only micromets. It's hard to be very definitive about this. Generally, we don't support treatment in the micromet context. We think that it's quite all right to forego any axillary-directed treatment in micromets. Now, if you had a really extreme case of, 7 or 8 nodes with micromets, we would revisit that in the context of the other risk factors, of that case. In fact, for any micromets, we have a risk table that we use of other, what's the subtype, how big is the primary tumor, et cetera. So on a rare occasion, we will, even for just a 1 micromet case, we'll offer PMRT, but we've set the bar very, very high. We would have to really have the perfect storm of all these other, bad things happening to do that. Just to be clear, we don't think radiation, RNI or PMRT is needed for the overwhelming majority of women with micrometastasis.
Add that the IBCSG 2301 trial did allow patients with multiple micromets into the trial, and the axillary recurrence rates in that trial are very low. So.
Terry, there's a couple of people on that microphone.
Oh, I'm sorry. Thank you. Yes, please go ahead.
Yeah, Marisa Weiss, breastcancer.org. My question, Dr. Khan, about reirradiation. What dose fractionation do you follow? Do you use NRG 1014 or BID, or what are your options?
That's a great question, yeah. We used to use the 1.5 BID per NRG exclusively for many years. We've now switched to 1.8 daily to 45 gray, which is biologically very similar, and we think that the once daily dosing allows, there's extrapolation from other data, but the once daily dosing is better for fibrotic complications and things like this. So we've gone to 1.8 once a day to 45 gray.
Thank you.
And Dr. Khan, what's your selection criteria for offering repeat radiation? Is there a length of time between the initial radiation and the subsequent recurrence? Is it subtype restricted? How do you all choose?
Yeah. Well, the trial that was just referenced just had a minimum of 1 year. But number one, we like to see these patients before their surgery, and they get sent to us by the surgeon so we can evaluate them. It has a lot to do with their bra cup size, kind of also how their breast looks after that first course of conservation, the interval, as you said, Tari. All of these things sort of go into the likelihood of a successful outcome with the second course of breast conservation. But I will say that the majority of women are kind of suitable for it. So it's...
Thank you. Over here.
Ian Conkler, University of Edinburgh. I wondered if you could comment on the role of molecular signatures of breast cancer radiosensitivity in terms of refining the selection of patients for the emission of radiotherapy. There's a recent meta-analysis from Carlson et al. Published in the JNCI of 3 randomized trials of breast-conserving surgery plus or minus radiotherapy in node-negative, ER-positive, HER2-negative patients, in which the mRNA signature of POLAR, the profile for the emission of adjuvant radiotherapy, identifies a POLAR low group, which had no benefit from radiotherapy, and a POLAR high group, which had a significant benefit.
Yeah. No, I think those data are actually very promising. Those expression assays were developed, trained, and validated on radiosensitivity, as you said, rather than just other, let's say proliferation or whatever. And so I think that the data are still early, but we're still, in need of like the prospective. I think the prospective demonstration of prognostic and predictive value is still sort of in development, but I think it's very promising.
Okay, we have a question that I'm going to pose to all members of the panel, including Yvonne. So the audience wants to know, are we making axillary management more complicated than it needs to be, especially when most adjuvant decisions are based on genomic assays anyways? So, Dr. Khan, why don't you start?
I think it's a valid question. It's almost to the extent, not just axillary, even at the primary, a lot of, like for example, adjuvant radiotherapy is being decided by some of these expression assays, or the utilization of adjuvant radiotherapy. So are we perseverating over minutia, right? Is that like, are we just, someone asked me that, I was mildly offended actually. But we have to remember that many women are diagnosed with breast cancer every year. So we do have to be very careful about changes in our practice, and because it can affect many women just in absolute terms, just because there's so much breast cancer. So I don't think we can be too careful. I would kind of reject that notion.
Dr. Wong?
Yeah, I would say yes, probably we are making it more complicated than it needs to be. But I think it's just very reassuring, as Dr. McLaughlin talked about, this sort of wave of de-escalation that we've seen, going from clinically node-negative patients now to clinically node-positive patients post-neoadjuvant chemotherapy. And so I think that will just continue and make, hopefully, things more simple in the future.
Yvonne, what are your thoughts as a patient when you hear us going back and forth with these different options?
Well, I understand that there are procedures in place, and the medical professionals have designed different ways that they want to treat the patient. But the reality is that the patient just wants the best outcome for themselves. And so however it takes to get there, as long as we continue to include the patient's voice as you make these decisions, I think that's the best road in this for me. Mm-hmm.
Thank you.
So I think biology trumps everything. I think that the axilla is clearly diagnostic these days and not therapeutic. And I don't care which trial you look at and which setting or anything like that, because what you see in all these cases is that the isolated regional recurrence rate is like 1% in almost all cases, before chemo, after chemo, node positive, whatever, it doesn't matter. So, we do a lot of harm with patients when we do axillary dissections. It's pretty morbid, and frankly, when they come back, that's about the only thing that they complain about is the arm incision and their arm and those types of things. So, I have become less and less, interested in dogmatically performing axillary dissections on all patients because of that harm. And if we reserve it, and remember, a lot of these patients are getting radiation, and that synergistic effect between axillary dissection and radiation essentially doubles the risk for lymphedema. So, I think, moving to a situation where we consider axillary dissection for isolated regional recurrence, and doing it for those patients, I think, may have some value in the future.
And final question at the microphone.
Thank you. Ellie Prusaloglu, I'm a breast surgeon at Yale University. I'm wondering, with the more widespread implementation of the SOUND trial and considering omission of any sentinel node or any nodal surgery on women with negative axillary ultrasound, how do you in your practices interpret extensive LVI on the breast specimen? We're now seeing new gray zone where we know women are clinically node negative up front, and we have these other sort of high-risk findings in the breast pathology itself. Is this something you and your centers have developed an approach for?
I guess I can start with that one. Yeah, I think we will have to look more at factors that are present in the actual breast specimen, as we, of necessity, will have no nodal information, right? And I think LVI, an extensive LVI, does factor into that. We actually looked at this not too long ago. You'll find a paper that with me as a senior, looking at no LVI, usual LVI, NOS, or extensive LVI. Actually, and also focal, so there were four categories, demonstrating that the extensive LVI actually was worse than usual LVI. So I think for us, for the indications for regional nodal radiation, or also, for example, PBI versus whole breast, we will have to rely more on those factors. And I anticipate people will have, well, there's going to be the expression assays, but there's also going to be clinical pathological nomograms that people are going to be using, for that kind of thing.
I can comment in our practice at Dana-Farber, we did come to a consensus of the patient population that we would apply the sound criteria to, and the presence of LVI on the core biopsy is actually an exclusion criteria for us right now. So our multidisciplinary team was not comfortable with us applying sound to patients with LVI on core.
What if it's incidentally found on final pathology?
Excellent question. So there are some cases where they may have LVI, they may have higher grade disease than what we agreed upon. And so there are some cases where we do have to discuss whether it is necessary to go back to the operating room for a sentinel node procedure. And that is, in the form of a multidisciplinary discussion, tumor board, how important is that information about the node really going to be?
Thank you.
Any final comments from the panel? All right, well, thank you all for your attention this afternoon, and enjoy the rest of the meeting.